Namaskar. On behalf of Raipur Obstetric Gynec Society, I welcome you to this, sort of clinical meeting hosted by Raipur Obstetric Gynec Society and Society of Fetal Medicine. Dr. Khurana sir has, very new and unique ideas. And the best thing about this program today is what Dr. Bimal Sani just said, that this gives a different perspective to the radiologists who are doing the work. And if I'm a gynecologist, and what I would like to say is that it gives the gynecologist a different, approach to the fetus and the mother, that if something is happening to the mother or to the child, then how it's going to be seen objectively in a way that we can measure. And one thing that I learned by a couple of cases, that how you measure is really important. So what SFM does is teach you the exact way how to do it, which charts to look at to see whether what you're doing is right, and always to have yourself monitored by your seniors. That seniors means those who have been doing it longer, so that you know what you're doing is right. Otherwise, you start doing something wrong and you do it wrong forever. So this is a really good learning platform. Thank you, Khurana sir. Thank you, Aparna madam, our honorary member of Raipur Obstetric Gynec Society. Welcome, and I hope you take the program forward, and all of us clinicians really learn a lot from it. Welcome.
So a very good evening to all of you. And I would like to thank the Raipur Obs Gynec Society and SFM for continuing to hold these monthly meets. This time it's going to be a little different. This is related to clinical management of anemia in pregnancy, along with a case on fetal anemia. So why we are doing this? So anemia, as sir said, is like, doing anemia with an SFM touch. But yes, anemia is something that we see day in and day out, and it is everywhere. So today we have with us our esteemed panelists, Dr. Jyoti Bhaskar. She's from East Delhi. She's a senior consultant from East Delhi. Dr. Chanchal, I know most of you would be knowing. She's a fetal medicine person, essentially handling the fetal anemia part, but I'm not going to leave her on the maternal anemia questions as well, because we are together postgraduates and I know that she loves obstetrics. Dr. Tamkeen, she's a senior consultant professor from Aligarh, JN Medical College, Aligarh, and it is interesting that she has started a Stillbirth Society of India, the very first Stillbirth Society of India, and there's lots to do with her, and she's very active academically. So welcome, ma'am, and we're really happy to have you with us. Dr. Savita Singhal, again a very senior professor from PGIMS Rohtak. So we have worked together on quality improvement projects, and that is how I have come to know all of Dr. Savita and Dr. Tamkeen. So now we are interacting more on obstetrics. So we really hope that you will find this episode useful. We will be going case-wise, right from the simple things about anemia in pregnancy. So this particular lady comes, she's a 21-year-old primary gravida, comes to OPD at 4 months of amenorrhea, and she's currently 16 weeks pregnant. So as usual, you advised her routine investigation. So on her investigations, her hemoglobin comes out to be 9 gram%. So now what will we do next? I would like to begin with Dr. Jyoti Bhaskar. Ma'am, so what would you like to do next? Simple things, hemoglobin 9 gram%, it comes to you every day. So what will you do about it?
So when we are going to take in this particular patient, 9 grams means that she's going into a moderate anemia. So important as an obstetrician is not just to go for investigations, but I would first like to take a history, do examination, and then move on to investigations. And the main aim of doing all this is to find out the cause of anemia, and second, the severity or any symptomology that she has. So I'm not going to touch the history and examination, but straight away move on to the investigations. And the simplest thing that we can do is a complete blood count with a peripheral smear. When we're looking at complete blood count, it's not just the hemoglobin we are talking about. We are going to be talking about various other important indices which can tell us exactly the type of anemia that she has, especially the MCV we are going to have a look at, the MCH, the MCHC, the RBC count. We are looking over here at RDW. That's a very sensitive marker of iron deficiency anemia, as well as ferritic count. If we have a look at all of these particular itself, we'll be able to decide what type of anemia she's going to be having. And peripheral smear, of course, is the mainstay because we know whether it's microcytic, macrocytic, along with the MCV, that can also be able to tell us.
Right. Ma'am, would you like to talk about the stages of iron deficiency, which is important in terms of, clinical practice? Like here, the patient has become 9 gram. So this is already a second stage.
So actually, it depends upon first how we develop anemia. When a patient does land up having anemia, that is when your hemoglobin is falling below 11. That means your iron levels have been totally depleted. That's why you land up having anemia. Initial stages is just an iron stone. Then we have further depletion and then it tends to go on to that. So depending if your hemoglobin has come down, that is it's gone below 11 grams in pregnancy, we are going to divide them into mild, moderate, and we're going to divide them into severe anemias. So when we are talking about the mild anemia, it is between 10 to 10.9. We're talking of moderate is 7 to 9.9, and below 7, it's going to be severe. And WHO just stops at that, but we have in the ICMR, they even go very severe, that is below 4 gram percent. So we have the tests that we are going to be talking about are the one which decides the severity. And these tests also tell us that about the iron stores that are present. So that will help us decide exactly how we need to move ahead with the treatment of it.
Right. So this particular patient had evidence of microcytosis. That means the MCV was less. So I would like to know from Dr. Tamkeen, ma'am. So essentially we just send one test to say that, okay, there is some microcytosis, but when we talk about small RBC, so what should we think about? Is it just iron deficiency, or how do we test for microcytosis and how do we go about it?
So basically the normal MCV should be around between 80 to 100. When it is less than 80, it is microcytosis. But usually we assume that it is because of iron deficiency, when there can be other causes of microcytosis as well. So one of them is thalassemia, another is sideroblastic anemia, then lead poisoning, copper deficiency, chronic or acute inflammation. All these can also lead to microcytosis. So these are the different causes. The value is between 80 to 100. When it is more than 100, we know it may be because of folic acid or B12 deficiency. Less than 100 could be because of many causes. What is important to know is that initially there'll be only depletion of the iron stores and the iron that is available to the tissues. So patient may have a low hemoglobin or patient may have even a normal hemoglobin, but she may be symptomatic. So because it is a very important respiratory coenzyme at the level of the tissues, iron. And that is why people will be ignoring her complaints in pregnancy. So that is important. And maybe she will land up with anemia later on. So when we have little time for correcting it. So that is important. That is one of the pitfalls. And of course, initially you will find that there will be normocytic RBC, but the deficiency will be there. So ferritin will be the earliest, which will point to us that there is a iron deficiency occurring.
Right, ma'am. So thank you. Yes, ma'am. So microcytosis is something which is very, very important, but it may be masked in pregnancy. So it might not be there till a later phase of pregnancy. So even if the hemoglobin is going down and there is obviously along with iron deficiency, there is B12 and folate deficiency, which again, takes the RBCs to a larger size. So microcytosis might be, kind of masked in pregnancy, which makes it a bit more difficult to understand. So now, as Dr. Tamkeen ma'am said, that there is a role of ferritin and additional iron indicators. Now, all of us are coming from varied resource settings. Some patients cannot even afford hemoglobin, and some patients have the entire battery of tests available for them, which is like 10 tests available. So ma'am, we would like to know more on when should we do ferritin? What is the role of ferritin? And when should we do the additional hi-fi markers, for iron deficiency, the whole battery? So what is the indication to do?
Yeah, actually in our setup, if patient 9 gram percent, which is most of the patient, I think more than 50% of antenatal women are coming in 9 gram percent. So straightway we cannot go with the ferritin. Even the microcytosis may be masked as discussed. We go for a complete hemogram with the peripheral blood serum. If a microcytosis is there, straight away we start with the iron therapy for the patient. Don't go for the ferritin all the patients. So in the beginning, 9 gram%, I don't think there's a role of, though if they are going to Metropolitan Hospital, they straight away write the ferritin, transferrin, total iron binding capacity, saturation. So definitely if it is iron binding, this iron deficiency anemia is there and it is little higher. This is moderate, less than 7. I would like to go for these ferritin, all these tests. Or if patient not responding, we are given the iron therapy for 1 month or maybe 1.5 months, and same hemoglobin is there, then we are doubtful whether it is iron deficiency or it is so many causes of microcytic are there, maybe chronic illness, this chronic diseases, or thalassemia, or even this lead poisoning also can lead to microcytosis. If it is not rising with the iron therapy, then definitely I will go for this ferritin and all those things. But if patient can afford, then some people are advising ferritin, but I don't think it should be the first line of the investigation. If 9 gram% is hemoglobin is there and there is microcytosis. Basically, it is not only the iron. What is seen in present scenario, it is not the iron deficiency. It is a nutritional anemia. Basically, these are combined. So only iron is sometimes not going to help. Now, what is recent scenario which is seen in our hospital? It is megaloblastic as well as dimorphic anemia is there.
Right.
So only iron is not helping. So we have to combine with the folic acid and what is the scenario nowadays? So folic acid and these vitamin B12 has to be combined in most of the cases.
Right. So we were talking about the microcytic anemia and the megaloblastic anemia. But what is important also here is, like ma'am rightly said, there is something called a therapeutic trial of iron. Right. So if a patient comes with iron deficiency anemia and she's not very severe, between 9 to 10 grams, so maybe we can start her on iron. And that is when we decide that, okay, give her a therapeutic trial. If she's not responding to therapeutic trial of oral iron, then we go for investigations. What is very important about ferritin is that it is the first marker to get reduced, which can be actually be detected on an investigation. So it is the first marker, the cutoff of 12 to 15. It is, that the iron stores are low, but anywhere less than 30, we know that the iron stores are low. So a low ferritin level is diagnostic of iron deficiency. So this is a very interesting concept here, that if it is less than 30 or less than 12 to 15, we know that it is iron deficiency. But if it is in between 30 to 100, we don't know that the iron deficiency is not there. Why? Because it is increased in the states of inflammation. So when we are testing for iron and it is less than 15, we know that it is iron deficiency, but between 50 to 100 might be increased because of inflammation. And that is the point where we would like to, do the additional test. So Chanchal, would you like to come in and comment at this stage?
Yeah. So as you said, Aparna, that once it is very low, then we are very sure that this is iron deficiency. However, when the ferritin levels are indeterminate, then we need to look for other causes of anemia. And for example, the most common can tend to being beta thalassemia because the presentation overlaps with iron deficiency anemia. So one would want to investigate on the basis of other investigations, including red cell distribution weight, the Menster index, and the other indices, and rule out beta thalassemia.
Right. So here the point that we want to make is that it is not a blanket testing that we should advise for everybody, that you go for TIBC, serum iron level, transferrin saturation, just because it is available and affordable. So it is not necessary to do all the investigations in one go. If we have a therapeutic trial of iron which has failed, or if it is not indicative of thalassemia, which will be coming soon, on the red cell indices, then we just go for a ferritin. And if it is low, it is low. If it is more than 100, we know that there is no iron deficiency. Between 30 to 100, we need to go for the other markers like TIBC, low serum iron, and low transferrin saturation to know that, okay, there is iron deficiency, we should replace iron, and it is not something else. So that is the role of additional investigations that we should be doing, and looking at serum iron, TIBC, and transferrin saturation. And the other problem with all of these is definitely that there is, in pregnancy itself, these values do not really mean so much as in a non-pregnant women. So we should not be jumping onto these investigations for all cases of iron deficiency anemia. So Tamkeen ma'am, what do you do in your setup? Like, what is the reasonable diagnostic approach? Reasonable diagnostic approach for iron deficiency in our settings, or if it's a non-affording patient versus you can test everything.
So I just ensure with this thing, a peripheral smear, and keeping in mind that it is most of the time microcytic when it is iron deficiency. So we are quite sure that it is iron deficiency anemia. But whenever the history is more suggestive, maybe she's having more of neurological symptoms, or there's a dimorphic picture on a peripheral smear, or maybe some other investigations when the MCV and the ferritin do not match, then only the other investigations would come in. Because the cost of those total investigations would be around 2,000. Serum ferritin is 600, PIBC is around 250. So all those, definitely for a resource setting, we just start with the therapeutic trial and we see that the reticulocyte count or the hemoglobin, if any of them are increasing, then we are satisfied that most probably it is iron deficiency anemia. Right. It is only when it is in between, that is between 30 and 100, or when it is not matching, then only, or in cases of liver disease, maybe we will think of other investigations.
Right. So, ma'am, Jyoti Bhaskar, ma'am, I would like to
add one thing that
yes,
and low resource setting, I think this hematocrit and these MCV, PCV, we are going with that only.
Yes. Yes.
Not with the ferritin, that we go with these only, the hemoglobin, follow with the complete hemogram, PBF, and these hematocrit values.
So, ma'am, being the devil's advocate,
we dealing most with 99% of patients we are dealing with these only, these investigations. Right. If they're not responding, means after therapy, then we're going for these further tests in our settings.
Yes. So, Dr. Jyoti Bhaskar, ma'am, you don't really, really cater to the low resource setting. So, you are on the other side of the spectrum and you practice.
Yes.
So, ma'am, what is your point of view on it? Like, what is your practice?
See, in our protocol practice, as far as the first time when a patient comes, apart from doing the CBC, we always get an HPLC done to rule out thalassemia at the very first go. So we are not basing ourselves on the CBC. We already know that microcytic hyperchromic is not a thalassemic or a beta minor that is there. And then even in our resource settings, the only test that we do get it done is ferritin, and that is when they're not responding to our oral iron. We have given them an iron therapy. We get a repeat hemoglobin done after 4 weeks. And when we find that after 4 weeks also there's not even 1 gram rise, that's the time we actually go in for the iron studies to be able to find out. Even in the high resources, we don't just tell them everything. And also we associate to do other reasons why it has not grown. That means after 1 month, if you don't find a rise, then we have to find a cause. So then we're looking for other investigations like urine and everything to rule out infections and inflammations otherwise.
Right. So thank you, ma'am. I think we are all on the same page that, there are certain rules that apply to investigating iron deficiency anemia. And then that is what we follow for most of the cases. So, Dr. Savita, ma'am, so it is very important that, some things that we really miss, that we see the patients, give them medicine, send them away. But that is what really happens in our antenatal clinics most of the time. So if you want to give her an advice on diet on iron, what would you give? Because some points, 5 or 6 points, which are very, very important when we advise regarding diet for prevention and management of iron deficiency anemia.
Diet is very, very important. Very, very simple measures can improve your iron. And most of the people are not knowing what to be taken and how to be taken. So basically there are 3 things. 3 types of diets are there: low bioavailability, high bioavailability, and intermediate bioavailability. So we'll tell the patient which diet is rich in. First thing to tell which is rich in this iron. Basically these meat products are rich in. So most of us are vegetarians, so they are not taking, so we cannot go ahead with that. Then cereals, high protein diet, ascorbic acid, these lemon we can ask the patient, citrus fruits. These are again sprouted. That is again very, very rich in iron. Very simple things which I tell non-pregnant also, the young girls in the hostels. I just tell them keep jaggery on your dining tables in the hostels. So in the end, they can eat the jaggery after the meals, and keep lemon. So that with meals, you take the lemon. Half, आधा भी नींबू लेंगे, so it will increase the iron absorption so much. So that is only 5%. If you add on to iron, it can increase to be 10%. So another thing is the phytates, which inhibit the absorption. That is to be known. So what is the most common thing which some of the people are practicing? After meals, they will take the tea and coffee. So that should not be taken just after major meals. So there's at least 1 to 2 hour interval should be there in between the milk products and the main meals. And then again, we can say that cook the food in the iron, but that is not being followed. Though villages, they are still following the cooking the food in the iron utensils and take the high viability, that is the heme products is to be taken. They're very simple measures which can increase the absorption of the iron which already you are taking in your meals. And then adding on to these some leafy vegetables, they're very, very easily available. Chana, kala chana, leafy vegetables, jaggery, which is very easily available and not costly also. So these can increase iron absorption.
Yes, ma'am. And one important point is also about, don't take iron and calcium together. So I think that is
that is very important. Very important. Don't tell them that calcium.
Yes, calcium to be taken after meals, and iron is like 1 hour before meal, or there should be a gap of things like that.
In pregnancy, we have to tell about the iron also, how they, because we are giving the iron tablets to each patient. So that again has to be told how it is to be taken apart from the dietary, because it is supplementing all the patient. So we should advise them it should be taken half an hour to 1 hour.
Yes.
Before the meal.
Come to the next question to Chanchal. Chanchal, you are the obstetrician. Sorry, you are on this side also today. Right. So what is the dose of oral iron given for prophylaxis for mild anemia? I'm sure you see some of the patients.
Yeah. So for prophylaxis of mild anemia, 1 tablet of iron folic acid is prescribed containing 60 milligrams of elemental iron and 400 or 500 micrograms of folic acid. And for treatment, 2 tablets of the same composition should be taken for at least 180 days or throughout the pregnancy and the 3 months of lactation.
Yes.
And, this is the daily regimen, and there is an intermittent regime also, which is better tolerated. So this is your GCPR, the FOXI guidelines, the good clinical practice recommendations. So the table is there that in a week, if patients who are not very tolerant to the oral iron tablets, they may take it weekly with the 120 milligram of elemental iron and 2.8 milligram of folic acid in that tablet once weekly.
Yeah. So, and I'm sure all of us who have given iron, we know that, it is difficult to take. So there are various methods to let go of it. But another interesting thing that has changed recently with this Anemia Mukt Bharat guideline is also the dose. Earlier it was 100 milligram.
Yes.
Right. So this is something that we need to know, that even in India, the dose has come down to 60 milligram. In fact, WHO says 30 milligram. And where in places which are not iron deficient, but in our country the dose has come down from 100 milligram to 60 milligram even by the Government of India guidelines. So this is something because it is easier to take, and more than 60 is actually not absorbed. So I think that is something that is important for prophylaxis point of view. So for mild anemia, Chanchal, can we just go on to that yes, you already mentioned.
Yes.
Only one thing I'd like to add, Dr. Aparna, over here is that I'm being on the other side. So with this, the private practice, we are writing medications, the iron therapy. So one point that we really need is it's only about the elemental we are talking of. So whenever we see the various medications we're giving, ferric, we're giving, it's already 325 milligrams, or you have 500 milligrams, and we think we're really giving them. So we need to find out what is the element content of this. Elemental that we need to focus to be giving minimum 60 milligrams per day.
Right. Ma'am, the Government of India gives us the iron ki lal goli and the neeli goli, right? Yeah. So that is actually 60 milligram elemental iron, and that is parasulfate. And a lot of studies have actually said over and over the years that whichever iron you give, it's all about side effects. It's not the dose. Everybody has the same absorption efficacy. It is just the side effects which are different with different, things of iron.
Preparations. Yeah.
Iron preparations, yes. So the only thing that regarding mild anemia is that we give 2 tabs to begin with, and then we should do hemoglobin after 1 month of treatment. And as ma'am said, if it doesn't improve, then we look for the causes on why it is not improving, and maybe we need to go into the this thing. Now, this is one major confusion that can happen, that patient is anemic, 7 grams per first trimester, ma'am, would you give iron? You would not give iron.
Yeah, as you rightly said, it's a big confusion in the minds of all the obstetricians. First trimester, is it going to be teratogenic? If I give an iron, is the baby going to be affected? And patients themselves are very, very, I would say, they do not want to take any medications in the first trimester. But if you look at all the guidelines do not say you cannot give it. If you look at the CDC guides and ACG, they say if needed, that if you're very sure she's moderate anemic or she's going to be there, you need to give it, you give it. The only problem that we do face is in the first trimester, they already have a lot of gastritis and problems with the absorption. So if you're adding on to iron, then tends to make it even worse. So that's a very practical point. But yes, evidence is not too much in favor of it causing teratogenicity. There are some animal studies, but I don't think there are any per se strong evidence in favor of saying that it is teratogenic. So if the need arises, if you really feel your patient is moderately anemic, there's nothing wrong in giving them. And we instead should be giving, but otherwise as a routine, no supplementation. And I think the Ministry of the Health also and the ICM has very clearly said at 14 to 16 weeks to be started iron for a pregnant woman.
Right, ma'am. I think that's the practical point. Yes, ma'am. Somebody wanted to say.
Yeah, I just wanted to say that in the first trimester, because of the nausea and vomiting, they may be less, able to tolerate oral iron when given. That is another reason why we try to avoid in the first trimester. Apart from that.
Yes, ma'am. So coming to because you've said about the gastritis and vomiting, ma'am. So it is not just the first trimester; it can happen in second and third trimester as well. So when the patients come to you,
we should not go by the message that iron can be given in first trimester. Only rare instances, hemoglobin moderate anemia is there, less than 7 or it is 8, less than 8. Then we can go with that. Otherwise, message should be that iron should not be given in first trimester. Otherwise, everybody start giving iron even if it is 9 grams per cent. So that should not go, I think. But we said,
so Dr. Savita is a little more conservative about it. But yes, I mean, we can have different viewpoints, but unnecessarily why we want to trouble the patient by giving iron in the first trimester, because essentially the fact is that there is no increased iron requirement till the first trimester. So it is not definitely increased. So it's not like an absolute necessity to give unless the patient is actually moderate going towards severe anemia. That is the situation when you would like to give. Yes, ma'am. So Dr. Tamkeen, ma'am, so in general, what would you give the advice on preventing the adverse effects or decreasing the adverse effects of iron?
Diarrhea, constipation, abdominal pain, tarry stools, heartburn, all those things are the side effects. So usually, but the absorption is definitely better on empty stomach. So if she's able to tolerate, then at least 1 hour before meals. If she's not able to tolerate, then 1 hour after meals. And then, like Dr. Savita already said, a lot of citrus food or vitamin C or citrus fruits or a fruit juice may be added to it. So I think that's it. And maybe if she's not able to tolerate and you have to give it twice a day, start with a smaller dose. And then when she becomes used to it, then she can increase the dose, maybe make it twice a day if required.
Right, ma'am. So like we can actually change the alternate.
So one more thing can be done. We can give at bedtime. If it is not tolerating at all, we can give 1 to 2 days at bedtime. She takes the tablet, sleeps, and then in the morning she may be okay.
Right. So, and also we can, here is the role where you can change the preparation.
Change the preparation, yes.
Yeah, so here there are certain things which have a lesser, GI side effects. So the more costly, but lesser side effects, yes. So this was about, microcytic hypochromic anemia, iron deficiency anemia coming to us in the first trimester, in the early second trimester. But another lady with a twin pregnancy who's coming to us at 34 weeks of pregnancy. And hemoglobin is 8.5, taken oral iron given at PHT according to her, but on investigations now she has iron deficiency anemia. So what would you do about it?
She is having multiple pregnancies and she is 8.5 in spite of taking oral iron at PSC. It means she is not very compliant. Moreover, she is multiple, we have to get her HP little more. So I will, in this case, thinking she's non-compliant, I will like to give injectable iron to her. So she's already 34 weeks and she's multiple pregnancy and she's fitting into the moderate anemia. So I'd like to give the injectable irons. Now, which injectable iron to be given, whether IM or IV? So it all depends because what I am comfortable with IV iron. The IM is a little more side effects. It has to be given alternate days, 100 milligram. At least 10 injections are to be given, painful, abscess formation can be there. And IV, you have to admit, that is the main reason you have to just...
Ma'am, I would like to know, are you still giving IM iron? Are you giving IM iron? I'm
not giving IM iron at all. I think in rural areas, there's some practicing still now. I think in rural they're practicing. Some patients coming with us that they have been giving iron in rural areas.
Yeah,
They're still getting.
Yes, ma'am. So these are also
Otherwise,
the
in our
anemia.
setup, we are giving IV only. So I prefer IV. This is a route of preference for IVR.
Right. So here is the guideline, which also says that if it is less than 34 weeks, but non-compliant to oral iron, or more than 34 weeks, it is better to give IV iron. And we have both preparation, iron sucrose and FCM. So I would like to know from Dr. Jyoti Bhaskar ma'am, what do you give in your practice? Do you give both, or do you give FCM? How do you go about it?
So in my practice, I always prefer to give the FCM to the patients. I counsel them. The only problem with the FCM is that the cost. So if the patient can afford the particular cost, the ease of giving it as a total infusion at one particular time, at one sitting, it's given over a period of 20 minutes itself. And then the side effects that I have found with it to be literally minimal when we are giving on to that maximum. Sometimes the patients do complain a little itching here and there, but we have not found to have any major anaphylactic or any other side effect. The maximum dose, there are two vials that we get. One is of 500 ml. So we are normally, depending upon the calculated deficiency of iron that we have. So 1000 milligram maximum at one time. If I need to repeat it, then I would repeat it after 1 week. And we found a very good response. In my own practice, I have seen that nearly about after 3 weeks or 4 weeks when we get it on, there's been an increase of approximately 3 gram%. Also, we have noticed that much of a good increase. So the calculated dose, of course, this is the old formula, which we somehow I don't remember and I need to see it each time. That's 2.4 into target. Target hemoglobin we are talking over here is 14, minus the actual hemoglobin and pre-pregnancy weight. So we are not measuring the weight today, but it's a pre-pregnancy plus 1000 milligrams we're going to add because we need to replenish. We take the total amount of this with the FCM, we divide it. But yes, iron sucrose is also good. For the patients who cannot afford it, iron sucrose also is equally good. Only thing is that you need to give the injections twice weekly, and then you calculate the total dose and give it. So it can be given about 200 milligrams per each time. Again, in the normal saline that we are adding 200 ml, given slowly. Very few anaphylactic. I have not seen a single anaphylactic reaction, even with the iron sucrose when it has been given. The initial is given slowly so we can check out over there. And this is yet another drug which is very effective. So we have a choice between the two. What I feel is it is the cost, which is a major factor, which one needs to look at it before we tend to give either of the two. Yeah.
So thank you, ma'am. And I would just like a quick comment from Dr. Tamkeen and Dr. Savita, FCM or iron sucrose?
So if you calculate the dose, the number of sittings, the number of times the patient has to come to the hospital, I think dose is not such a, sorry, the total cost comes down. I mean, it's comparable.
So you're giving FCM.
One is category B, another is category C. That is something which really sometimes, you think twice.
Dr. Savita ma'am, FCM.
We are using sucrose mainly because it is free from the hospital supply is there. And the cost is there. Moreover, it is not FDA approved in India, FCM for pregnancy, I think. It's better to say it's not FDA approved till now in India.
It is, but we have, yes, but it is mostly
but still
practical.
It is not, we are also using few patients who can afford, because 2,000 to 2,500 rupees is the cost for one injection. If patient can afford, sometimes she's not willing for the admission to stay in the hospital, we are giving. Yes, right. We are giving, but in most of the patients, we are giving ferrous sucrose only.
Right. So yes, I mean, and we are giving FCM mostly, even in pregnancy, because it is for us, it's in the hospital supply. So that's not an issue for us, but yes, it's possible to give. So would like to know from Dr. Tamkeen ma'am. So now you've given the whole dose of iron. Would you like to continue her on the oral prophylaxis? Because this is one of the confusing aspects that, okay, you've given her the total dose of iron. Would you like to continue her on oral iron prophylaxis, or we don't give it?
So we have already, if you have calculated the dose and replenished her stores as well. But during pregnancy, again, it will be required. So it depends upon whether she was able to tolerate it or not, and how much she was able to tolerate. So it has to be given even in the postpartum period.
Yeah. So I think postpartum period is another very important period that we need to start her on iron. Even if we have given her IV iron in pregnancy, that is something that we need to continue for at least 3 to 6 months.
3 to 6 months
in the postpartum period. So yes, so this was about the two scenarios of early and late pregnancy where we have to give oral iron and injectable iron. Now we come to the next scenario here. So if we see here, the MCD is 87, MCH is decreased, MCHC, there is dimorphic anemia. And if we look at this, the transferrin saturation is decreased, B12 levels is decreased, and folate. So this is actually our case from the ward a few months back. And we kind of routinely, we get some of these things done because it's available for us. But yes, in this particular case, because it was dimorphic anemia, we did get the B12 and folate levels, which were also decreased. So there is iron deficiency because ferritin is also low, and there is folate deficiency and the B12 deficiency. So this is a combination of iron deficiency anemia with megaloblastic anemia. And she is mid-gestation moderate iron deficiency anemia. So here this patient is, if you see, she is around 25 years, 24 weeks of pregnancy. Mid-gestation moderate iron deficiency anemia. What will you do for iron deficiency? What will you do for megaloblastic? So just what will you do for iron deficiency anemia?
We have to give the therapeutic doses in this actually. So already she is moderate anemia. We can give 120 milligram per day, is 2 tablets, depending on how she tolerates. So we can start with 2 tablets for the iron. And then along with that, we have to combine this folic acid as well as vitamin B12. This is the folic acid can be given 5 milligram per day. That is to be added. Along with that is therapeutic dose for folic acid, or for this vitamin B12. Though injections are available, that is a cobalamin injection, 1000 milligram, that has to be given daily for 1 week, then weekly for 1 month, and on a monthly basis. So this is usually we can give. And otherwise, what I have seen nowadays, the vitamin B12, these tablets, cobalamin tablets, are very, very effective. The 1500 microgram one tablet is coming, and that can also be equally effective. That can be given orally. Patient, their sublingual tablets are there. A very good compliance is where these cobalamin tablets. So that tablet can be given daily for 1 month, and then can be weekly basis.
Right.
So we have to multiple treatments.
Yeah, I agree with you. Here, the important thing here is that in a moderate anemia, for the last case, we started her on oral iron, injectable iron, but because she's just 25 weeks, we can start on oral iron and see if she's responding. So this is a little bit of a difference on mid-gestation moderate anemia, where we can start her on oral iron. Now, as you said, vitamin B12, we are also giving oral B12 now. This tablet has 1000 microgram that we have, and you can give it daily. And continue it actually throughout pregnancy. So it is actually continued throughout pregnancy, and this has a very, very good response. And with that, I would like to also talk, ma'am, would you talk about, like, would you like to replace folate first or B12 plus? Can you replace folate without B12, or what is the problem with that?
So if the B12 is the deficiency, we first need to treat the B12 deficiency, because folate is really actually going to mask mainly the neurological manifestations that can occur with B12. So it's important first to do the B12, and subsequently we can do with the folic acid also along with that. Now, as far as the patients, if they do have, we were talking about the oral or the parenteral B12 that needs to be given. It depends actually on how compliant the patient is with the oral. Does she have any neurological manifestations? What's the severity of symptoms she has? If either of these things are not there, I would prefer always to give her an injectable, because one dose you have given her injectable, you're sure that's going to go, because otherwise it takes a long time for it to be coming over.
Yeah, I completely agree with you. In fact, earlier we used to routinely give injectable. It is only now that maybe we give a few doses of injectable and then start her on oral B12s. More importantly, it is not just the folate, because folate is so easily available. You just start, and patient is already taking it, and we forget to replace B12, and that will actually worsen the problem. So that is something which is very, very important. So how to assess that whether my patient is responding or not? So this is something that it is very important when we are actually managing patients. So ma'am, how do you assess the response?
Actually, to see the clinical response, very, very, very important. Feeling of well-being will be a sense of well-being. In the LDH, one thing which is increase in these deficiencies. So if LDH is the very, very first thing which will come down once the effect of this treatment is there. So LDH will decrease, and retic count as with everything. Even if iron deficiency anemia, or it is a folic acid deficiency, vitamin B12, retic count will start increasing within 5 to 7. Even earlier, I will say 3 to 5 days. Retic count will start increasing, LDH will start decreasing, and feeling of well-being. These are 3-4 things which will be there with the treatment.
Right. So the response is actually the same, whether it is an iron deficiency or a B12 deficiency. But yes, importantly, reticulocytosis and hemoglobin is usually raised by 0.7 gram per week. So generally we see a response in probably 2 weeks time or a 3 weeks time. So it's important that we see. Now we come to the next case. We'll take 10 minutes on this case and then we will see. This particular case was another very interesting case that we saw. And, you know, when we actually take the rounds, you just look at the basic report that you have. And we see that the hemoglobin is 7 gram%. MCV is 58. So we know that it is microcytosis. However, the RBC count is 4.18. Okay, so now when we have to see the RBC count is generally given here. So it is RBC count is mentioned here, and it's a part of every CBC. Every complete blood count is going to have an RBC count. Can we determine from this whether the patient can have thalassemia or not? And this is what we are going to discuss, that yes, HPLC is good if it is affordable, the patient can afford it. But even without that, on a simple test, can we determine if the patient is likely to have thalassemia or not? So this particular patient had a low serum ferritin. So, you know, iron deficiency is all pervasive, whether thalassemia, whether B12, whether anything, iron deficiency is going to stay. That is the truth, universal truth for our population. So this patient had iron deficiency also, and the husband HPLC was normal. So the first question to Dr. Jyoti ma'am is that, you know, this existence of iron deficiency with the Menser index is 13. Would you like to comment on it? I think we'll just discuss this in a bit more detail, but with the Menser index, which is, you know, 13 or less, what would you suspect? And do you actually do this commonly in your clinical practice?
Yes, over the last 4-5 years, maybe we have started using, since we have started reading up the CBC very well. So Menser index is one of the sensitive indicators, and we can calculate it. That is just done by MCV divided by the RBCs. So if your Menser index is more than 13, then it suggests an iron deficiency anemia. And if it's less than 13, then it suggests thalassemia. And the main thing lies with the RBC, because we know that the MCV is going to be low in both the conditions. It is the RBC which remains in this to be low in iron deficiency, and it continues to be high in thalassemia. That is why we get this particular difference. So based on this itself, we take a cutoff of 13, more than 13, iron deficiency, less than 13, that is thalassemia. Now over here, since it is borderline 13, we are going to be saying in this particular patient. So I think that's where the significance of doing the iron studies come up over here. So we have over here that the ferritin is also very low, and we have got the TIBC also, which is found to be high. So this particular patient has a thalassemia. Along with that, she has a concomitant IDA is present. So both the things are there, and that is comparatively very common to be done. So when we were discussing about when to do a serum ferritin in the initial, I think this is one area that we do a ferritin, because thalassemia minor, we have been giving her iron, or they iron, do we increase it? So that's where the ferritin role comes, that are we going to give her more iron, or is it because of the thalassemia that it tends to last?
Yes. So even looking at a simple complete blood picture, we can actually say that, you know, depending on MCV and RBC count, so our hematologists routinely take classes for us that Menser index is something that we should look at. And this is something which is overlooked for all of us. Even if we are not doing an HPLC routinely in government setups or in your practice, if you're not doing HPLC routinely, please look at this Menser index. And if it is less than 13 or less, then we need to think about thalassemia. Then you get the HPLC done. So ma'am, how is the definitive diagnosis of thalassemia made? So in this particular case, she turned out to be thalassemia, beta thalassemia trait. So how do you, make a definitive diagnosis of thalassemia?
To go for the HPLC, see for hemoglobin A2 and hemoglobin F. And latest few, these genetic investigations are also in hand, I think, which can make definite diagnosis of thalassemia. Usually HB, if you go for hemoglobin HbA2 should be more 3.5% we take cutoff, and for HbF fetal hemoglobin take 2% cutoff. So if these are there, we can say the patient is having this thalassemia minor, or if very definite diagnosis, we can go for the genetic. That is, I think, I'm still under research. Thing it is there.
But all for all practical purposes, Dr. Tamkeen ma'am, would you like to add something here? Like what do you do in your practice? How commonly you do this?
So
in your area is thalassemia. Yes.
So in our, though it is the incidence has been reported as high as 3 to 5%, but we are not screening all pregnant women for thalassemia. But yes, Nestrov test is one test which can be done in low resource setting for screening. the osmotic fragility test, normal is 0.5 to 0.32. And then the Metzger's fraction is, of course, something very easy that can be done. And only when you suspect that you can confirm with HPLC, which will calculate the amount of hemoglobin A1 the percentage that is more than 3.5 will give you a definitive diagnosis. And then the higher studies, that is the DNA and all those at the level of the gene, that come on only later. For screening, I think Nestrov and or this Metzger's test, I think, should be.
So I think even in MAMC, Chanchal would say that we used to do Nestrov for everybody. At that point in time, we really used to feel that what are we doing? But yes, I don't know if the practice is still going on, but we used to have Nestrov for everybody. But yes, this is something also which is very, very common that we can actually look into. And when we talk about HbA2, that is
this ideally should be done in all the patients because it is so common in our part. I think more than 5% we are getting the patient. Most of the patients coming with the report of thalassemia minor, and we are getting ours only if she's not responding to iron. We say, okay, go for the thalassemia.
So it's all about
we have to protect the baby as well. See for that. So it is very, very important to preferably go for this universal screening.
Yeah. So Chanchal, so what are the specific conditions in which we should actually go for hemoglobin electrophoresis? Dr. Jyoti does for all. Any patient who's coming for anemia. But yes, it's all, it's definitely, so this is a desirable recommendation, something which has been mentioned in the antenatal guidelines that if it is possible, get HPLC done, especially in thalassemia belts. So that is something, but otherwise, in general clinical practice, patient is, not very affording. So what are the situations in which you would like to get?
As we've already covered in the discussion, and microcytic hyperchromic anemia, which is not responding to your oral iron therapy, you repeat the HP after a month and it doesn't improve. That's where you would want to look for other causes. And that's where thalassemia comes in. Also, in these kind of situations where your Mensa index is just 13 and not less. So these are, you can pick and choose. Not everybody, all reports will be like this. So when we have to optimize the use of resources, then I think these are the patients who would need it.
Right. So now that we have done HPLC, so I would just like to know, one of the common problems is that, patient is a known case of beta thalassemia. And so how do you treat iron deficiency anemia in beta thalassemia?
So in the same manner.
Yeah, that's rightfully Chanchal said. Exactly in the same manner. We need to just bring the point that, as you said, IDA is very common. Even if we have thalassemia, I would say more than 90% also would develop an iron deficiency. So we do supplement with the proper activities.
Would you give parenteral? That is the only.
Actually, we do not give just avoid parental iron in these patients.
No parental iron. It is only oral. It's only oral iron and transfusion if needed. That is when we have a particular criteria. If she's not rising, she's going to be less than 7, or she's reaching more than 34 weeks of pregnancy, she's going to be less than 8. Then I would consider blood transfusion at that particular time. Otherwise, it's only oral iron or blood transfusion, no parenteral iron at all in these particular.
Yes, so that is the point that I would, kind of say that probably we can avoid parenteral iron in thalassemia patients. But yes, like, we just saw the indications for doing ferritin is also if we are giving parenteral iron. So any patient who's receiving parenteral iron with a low ferritin level, it is not. So unless thalassemia is iron overloaded, there is actually not much of a problem with parenteral iron. So if we are doing ferritin in a case of thalassemia and it is low, then you can actually give, so our problem is iron overload in cases of thalassemia because these patients are already iron overloaded. But if they're iron deficient, it's not an absolute contraindication, but to be on the safer side, we give either oral iron or we give a blood transfusion.
Yeah. Right. I want to share one thing. Whatever patient we are getting in our institute, they are using mild anemia only. So they're not using thalassemia patients are not in the severe category to need the blood. What I have seen, they're using 9% or in between 9 to 10. Usually this is the level most of the times.
Yes. So Chanchal, finally one question for you. So how would you go about the prenatal diagnosis of thalassemia? And this patient's husband was HPLC was normal. So is there any role in this patient?
Please unmute yourself, Dr. Chanchal. Please unmute.
Chanchal can't hear you.
Yeah.
Yes.
Now. So can you hear me now? Yeah.
Yes.
So, I mean, so beta thalassemia being an autosomal recessive condition, if the partner is, if the husband is normal, then this patient does not need the prenatal diagnosis. And if the husband is also found to be a carrier, then we need to establish the genetic mutation of both the parents and then offer chorionic villus sampling in the first trimester for prenatal diagnosis. And if they come in late, if they come in after 16, 17 weeks, then amniocentesis should be done. The risk of miscarriage with either procedure is less than 1%. And it's usually the timing which is important, and knowing the mutations before and helps in expediting the reporting.
Right. So in this particular patient, because the patient husband is HPLC as normal, is not. So maybe we will not do a prenatal testing in that. So with that, we come to the end of this particular case. We just have one more case left for 10 minutes. So before that, Vishal, Mr. Vishal, can we have the as directed? Mr. Vishal?
Yes, ma'am.
We'll just take 2 minutes.
The trade videos, yes.
Yes, in between. Thank you. Yes, hi, welcome back. So I think with this, we will just go to our last case, and I would request inputs from Chanchal on this. So this patient came to us very recently. She was a third gravida, para 1 live 1, previous 1 abortion at 30 weeks and 4 days with previous full-term cesarean section, previous baby with a congenital heart block, known case of secondary Sjogren's. She was ANA and anti-Rho positive with McDonald circle largen C2 with she was being followed up for the mechanical PR interval also, but in one of the scans, she was detected to have fetal anemia to the limit that, you know, she had high drops also. So she developed MCA PSV, which was raised, and, you know, she had fetal anemia. She was Rh positive. So she was having a non-immune anemia. So, so Chanchal, I would like to just, ask you to go through the very basics of fetal anemia. You know, till now we have discussed maternal anemia, but some basic things about fetal anemia, like when do you call it fetal anemia? What is the definition of fetal anemia?
Right. So with the widespread acceptance of the non-invasive method of assessing fetal anemia, any MCA, PSV, so middle cerebral artery peak systolic value of more than 1.5 multiple of median for that particular gestation is accepted as fetal anemia, and it usually corresponds to a hemoglobin of less than 10% or a hematocrit of 30%. That's the accepted definition. And what was the second question?
No, in terms of hemoglobin, like you said, it is
right, less than 30. Yeah, a hematocrit of less than 30% or a hemoglobin of less than 10% would be accepted as,
So that would also be your limits of transfusion?
Right. That is when we would want to consider transfusion before the hydrops develops, because hydrops does not typically develop before it falls to less than 5 gram%.
Right. So what are the causes of fetal anemia? You know, we have really gone through the topics of RH isoimmunization, and everybody is well versed with the causes of immune anemia. And as I was mentioning, we have 3 patients of non-immune high drops, of which 2 actually have anemia. So what are the causes of fetal anemia that you talk about?
So the non-immune high drops is if you run into causes there, it will fill pages. The non-immune high drops due to fetal anemia, the causes vary. You've listed them here. The most common being parvovirus. That is the commonest that presents with fetal anemia. One must also look for atypical antibodies, even though the patient may be Rh positive. An ICT and an atypical antibody screening should be done. Anemia has been described with other infections also, like CMV, toxosyphilis. So in practice, I've not seen any with any of these infections. Parvovirus one comes across. And then there are other inherited causes. And because anemia, it may present with aneuploidy, in monochorionic twins, and more commonly we see it in fetal-maternal hemorrhage. That is another common cause.
Right. So these are some of the common causes, and I would like to say that we have really, bad cases where you have recurrent non-immune high drops, recurrent anemia in the babies. And then you have to keep thinking about what is happening. Alpha thalassemia is something which is seen in our part of the world. And if there is recurrent, every baby is having fetal anemia, then possibly again to alpha thalassemia.
Alpha thalassemia would usually present in the early second trimester with the high drops.
And also it is difficult to diagnose alpha thalassemia.
Yes.
It doesn't get picked up in HPLC unless it's actually hemoglobin bars.
Absolutely.
So that becomes a bit of a difficult diagnosis. So as you've already told about that, when do you suspect fetal anemia is when the MCA-PSV is raised, and you've talked about it, that yes, if you have a raised MCA-PSV, you have a doubt of fetal anemia for some reason or the other, then you start thinking about it. So how will you go about it? How would you investigate a cause of fetal anemia?
Right. So once we are suspecting fetal anemia on the ultrasound, when the MCA-PSV is above 1.5 mom, one would want to do an ICT for the mother, an RH blood group. We're presuming that she's positive. We would want to do an atypical antibody. One would want to do a Kleiner-Betke and an HP electrophoresis and torch serology, both including IgM and IgG, and also parvovirus IgM IgG. And so there is a lot of detailed anomaly scan along with a fetal echocardiogram, but here we are specifically talking about anemia, fetal anemia. So these are the tests that one would want to do for the mother.
Yeah. So generally, we do hope that, we get a reason for fetal anemia out of these. But sometimes, the cause really is elusive. We don't know anything about it. And yes, and we have done chordosynthesis to look for lysosomal storage disorders, biochemistries, enzyme levels. So that is the next level when you have, recurrent fetal anemia, which is, every time the baby is having high drops. So this is some of the detailed investigations that we had to do in
targeted clinical exomes encompassing all these inherited metabolic disorders.
Definitely, yes. So that is the next step that you would like to do, even a clinical exome. Yes. So in this particular patient, she was admitted and her PSV was more than, she turned out to be parvovirus positive on amniotic fluid also. So the IUT was done, but parvovirus has this special ability that it is only transient. So it is there for some time. There is high drops, then you transfuse blood, and then the patient actually recovers. So this patient delivered with us at 33 weeks and 5 days because she had little growth restriction, and postnatal ECG was normal, and the baby went home fine. So this was all about, the fetal anemia in brief, that, you have
one comment. Can I make a comment, Aparna?
Yes.
In cases where we were not expecting this fetus to be anemic, and parvovirus is very rare. So there may be a false positive rate of MCA-PSV. So one has to be very careful with the described technique of how to measure it, ensure that one is not placing too much of pressure, and to ensure that they're not, it is basically, one must ensure that it is not a false positive MCA-PSV.
Yes. So could you just describe the method for doing MCA-PSV, because we have a gathering here.
So so in the original paper by Mari, who gave the MCA-PSV, what they say is that this particular vessel was chosen because one is able to insunate at an angle of 0. The transducer, once you place on the fetal head, and once you go into the BPD plane, you enlarge the image such that the whole screen is being filled by the vessel that you want to insunate. Place your transducer such that the angle of insunation is as close to 0 as possible, and place the pulse wave gate of 2 at the level of distal 2/3 and proximal 1/3. And then you take at least 3 measurements. Don't put too much of pressure on the probe, because that itself can increase the velocity. And you take at least a minimum of 3 values and then take an average.
Yeah, very true. And also fetal movements, fetal activity
Wait for fetal quiescence before
quiescence is very important.
Yes.
So with that, we come to the end of the panel. So I would like to summarize that anemia is just everywhere for us. So I think it is, the more we treat, the more it grows. I don't know how it is happening, but holistic approach to prevention and treatment, we have forgotten, maybe we keep forgetting to advise on diet and, those nutritional changes and how to take iron tablets. So holistic approach to prevention and treatment, it needs to be adopted. Diet with fortification is something that we haven't discussed, but yes, this has also been found to be fortifying your salt and fortifying your, flour is also worked. So and IFA supplementation remain the cornerstone of management, parenteral iron therapy has come to play an increasingly critical role. And this is something that has been, it's like, iron has to be given by parenteral iron in case it is towards the later half of pregnancy. And this has been taken up as a major strategy. So with that, we come to the end of the panel. I would like to really thank all my panelists for their presence here and their inputs. So thank you very much. And thank you, Dr. Asha Jain ma'am. Thank you, Dr. Khurana sir, for having us here. Thank you so much.
Thank you to Society of Fetal Medicine, Aparna and Dr. Khurana for including us in the panel. I learned a lot.
Yeah, thank you.
And Chanchal has voiced on behalf of all of us panelists. It's been a pleasure to be here. Dr. Khurana and Aparna.
Thank you to all the panelists, and thank you, Dr. Aparna, for taking us through this. And we have a few questions in the chat box, so may I request the panelists to stay on. It's not a very crowded chat box today, which means that we did have some very convenient principles to follow. And I'm so glad there was so much clarity. The one question is from Dr. Seema Chawla: can we give parenteral iron in the first trimester in moderate anemia? So Dr. Tamkeen, would you like to answer that?
So I think we already discussed that iron in any form should be avoided in first trimester because of those teratogenic concerns.
Yes.
So better to avoid.
Yes. So,
and I think the main reason is we don't have enough safety data as far as the parenteral iron is concerned to be given in the first trimester.
True.
So yes, we should avoid.
Yes, I think this question was asked from the point of view of the fact that it might have fewer GI symptoms, but I don't think that is the consideration here. The consideration here is actual safety of iron in early pregnancy. We truly, as Dr. mentioned, don't have. Yeah.
And patients are, very much, they read up what they are getting, the treatment card and everything. They are very much aware. There are 110 causes of any anomaly. And if they find that it is a category C, they read it up and then they're going to blame you.
Yes, absolutely.
I think we should avoid anything that is not.
So it's very, very important to make sure that we don't have any controversial prescription at all. Then there is this question about the isomaltose preparation. And this is from Dr. Poonam Goyal. What is the experience with the isomaltose preparation by the intramuscular route? Would anybody have information on this?
This was earlier we used to give intramuscular. Right now we are not giving isomaltose as intravenous has come new, but we have no experience on that. So it is now getting more available, but we have not yet given it as intravenous. So intramuscular preparations are really, I don't know if anybody is still giving, maybe in the peripheral areas, but mostly we stick to IV iron. Isomaltose has come as a new preparation, but I have personally no experience with that.
So what should be our approach to when the pharmaceutical industry tries to throw education at us and they throw a product and saying, this is the answer to all your problems. What is a ready reference for any practicing obstetrician to go to see what is the true advantage of the fact that this is a designer iron versus a non-designer iron, and is it really true value for money? Well, what's a good reference?
We should not go by the small studies or by these pharmaceuticals who are promoting these. We should go by the guidelines, actually by FDA also, whether it's FDA approved or not. And the major chunk of studies, if very large number of patients, these studies has been done, then we can go ahead. Otherwise, the smaller these pharmaceutical people will come with very small studies on 50 patients, 100 patients, they present the results. So it should be well tested, especially in pregnancy. We're talking of pregnancy itself, so that should be well tested and then they should be prescribed.
I think Dr. Khurana is referring to the oral preparations that we have in the market.
Yeah, and
yeah.
So here I would like to add that if you actually look into the data, it is vast. Cochrane actually kills all kind of iron, oral iron. Cochrane says you take ferrous sulfate. That is as good as your any 30 rupees per tablet iron. So actually the results have not shown any improvement in terms of efficacy, whatever anybody might say. there might be some borderline improvement in the GI side effects. So we have to take everything that comes to us with a pinch of salt, and also look at and wait for the, look at those systematic reviews and meta-analysis which have actually shown that no form of oral iron is better than the other. So I had a question on that, but somehow I left it because it was completely a clinical question. So I should have kept that question, because there's enough evidence to say one form of iron is not better over the other.
Yes. Then, of course, there is a question. No, there is a comment by Dr. Shikha Singh reminding us that FCM reactions, though very rare, are well known to happen, and we should be ready for those when they do happen. Then Devasmita wants to know, do thalassemia E carriers require prenatal diagnosis?
So homozygous E is mild asymptomatic anemia. So if both the partners are HBE, they do not require prenatal diagnosis. However, if one of the partners is a beta thalassemia carrier, then the E-beta combination can cause transfusion-dependent anemia and warrants prenatal diagnosis.
And would that then be as serious as a hemoglobin D Punjab and a thal carrier, or would it be less serious?
No, so D Punjab beta thal does not require prenatal diagnosis. D Punjab does not require beta thalassemia diagnosis.
Well, because those are far more common combinations.
Yes.
That's what we do come across.
Yes.
And she wants you to repeat genotypes of father and mother in beta thalassemia. Do they help to detect genotype in the fetus?
I didn't understand the question, sir. The genotype of the?
I think she means the mutations.
The mutations.
So knowing the mutation is, I think, unless you are running against time, one would always prefer to know the parental mutations before offering a prenatal diagnosis, because most of the labs, they would offer screening for most common 5 mutations, and if they don't find it, they're doing the gene sequencing. Sometimes it may be very difficult to find a mutation, and that is when prenatal diagnosis becomes very difficult. So it's always preferable to know the mutations in both parents beforehand, and then offer prenatal diagnosis.
Yes.
I'm not sure if that's what she wanted.
I'm sure that's what she was asking for. Which brings us to this question on when should we screen a girl for beta thalassemia?
So most of the time,
if you ask me,
we get labeled and branded before she gets married and throw her to the vultures of the community, or should we do it after that?
At a prenatal counseling,
12 by 12 initiative is there. 12 by 12. She should have a hemoglobin of 12 by 12 years of age. If she doesn't have, screen her.
Yes.
The question that I want to ask everyone is, the cost of the HPLC test is not too much. We are varying from 500 to 800 to 900 rupees, and that's once in lifetime. So if we can offer them once in lifetime a particular test, that would be better than, because many people are not going to see the CBC. Many of them are not going to see, and we're going to have thalassemia major babies coming. So,
I mean, in government hospitals, I think even 500 rupees would be a big thing to ask for.
Yeah, well, I want to bring about the tragedy that we had in one of our programs that we tried as a program across the Yamuna. In those days, we used to call it Jamuna Park. And we carried forth a program where every single schoolgirl was checked by HPLC, because we had a grant for that from, in those days, was the USAID Foundation. All the 11 girls detected in the first 6 months were followed up, and all of them had the stigma of not finding easy weddings. Yes. So the question then arises, if she's anemic, yes, of course, we would do something about it. But actually do a screen in school, for instance, to catch them young. Should we ever attempt that, or in college to catch them, or should we just try and say, okay, preconception screening seems to be the best option? What's the opinion of our panelists on this?
Preconception would be the best.
And Dr. Parna, would you agree with that?
Yeah. So preconception. So this sounds very, very, tough. So I think preconception is an ideal time. So we have a battery of preconception investigations which should be done. So HPLC is a part of it. So actually we should be looking for preconception. Yes.
Yeah. And certainly not too much before that, because
we should think of deworming also. These young girls, deworming is also very, very important, especially in our part.
True, that would be, but the thing is that get a girl labeled in our part of the world prior to anything ever happening in her life is something that is very much possible, and we really have to prevent that. Then there's a very interesting question from Dr. Sahu from Ahmedabad, who wants to know how to treat parvovirus infection.
It's a self-limiting disease, so you don't need to treat it. But if it results in a fetal manifestation like anemia, it would warrant transfusion, as in the last case.
Yes, and up to when can this anemia occur?
Anytime in gestation.
Generally, it is there up to 12 weeks. So that is what we monitor. So once you have suspecting parvovirus in the mother because of something, so we can wait and keep monitoring for the MCA-PSV till usually not more than 12 weeks around that infection.
Thank you for that. And then there's a question from Aparna Setia. Is there any cutoff point till when we continue B12 supplement in dimorphic anemia? And do we then just keep it through the antenatal period, or do we then switch off B12 supplementation once the anemia is corrected?
So it is, sorry.
Yes, Dr. Tamkin, go ahead.
This to be continued weekly 1000 till even in the postpartum. Yeah. That is the recommendation.
Yes, absolutely. And the next question from Dr. Aparna Setia is a case of non-immune high drops. Which prenatal test should be offered? So for this, we say, okay, it goes beyond the purview of our seminar today. And we have some excellent webinars on non-immune high drops on our YouTube channel, which you can all see free of cost. I would request all members to actually go ahead and look at the vast varieties of subjects we've covered in our YouTube channel. And I'd request you to like that and make sure that you get notifications by subscribing to it. It's a simple thing. You just click, and you get subscriptions. So every time we have a new program which is up on YouTube, you'll be able to see that. And you'll find excellent studies there and panels there on non-immune high drops. Now, there was one question from Dr. Amrit Gupta on why do most patients tend to dislike intramuscular iron sucrose?
Iron sucrose is given or not intramuscular, it is given IV only.
Right.
But so they don't dislike the intramuscular because of the staining is there. It's a very painful injection. And the Z technique is used for the intramuscular injections. That is also very painful.
Yes. And then there was this excellent suggestion from Dr. Sasmita Das is why only girls, but boys should also be screened and girls are being screened. I fully agree with that. If we screen, we should just about screen everybody and make sure, after all, we have enough thalassememic boys also, and it's really an equal number. And then...
in some countries, they're screening before preconception counseling. They're screening both the partners.
Yes, but if ever we were to come up with a more open-minded society...
Especially in China.
Yes, then it would be wise to actually screen the entire population if we ever get down to it in our cultural setup. And then another question from Dr. Sahu, whether HPCL is the same as hemoglobin electrophoresis.
Yes, it is the same.
It is the same test. There are two names.
Hypoperformance liquid chromatography. Actually, there are various types which are available. So HPLC is something which is most affordable. So that's why it is done.
Yes. Also far more standardized, and there's not too much of a lab-to-lab variation on that. And that brings us to the end of the questions for this. And thank you to the panelists and to Dr. Panna for putting this together. It's the first time we tried a pure maternal medicine kind of situation. And, but not the first, but certainly something that was very purely maternal. And the question was that we had so many requests that, look, it seems to coexist in so many of our patients. So how can we handle this? So I think we will meet that, because all of this will again be on YouTube and everyone can refer to this as a standard reference again and again. Thank you so much for this. And back to our organizers, the Raipur Obs and Gynae Society, for the final words.
Thank you, Khurana sir. I see Tabassum is not here. So instead of her, I will say the vote of thanks. So I thank Dr. Khurana sir, who has so kindly agreed to hold these specialty webinars, which take obstetrics and SFM to a different level. I thank Dr. Aparna Sharma ma'am, who kindly consents to do the panel each time on a different subject, and each time they are done so very well. Thank you, Tamkeen madam, Dr. Savita ma'am, Dr. Chanchal Singh, and Dr. Jyoti. Thanks a lot for coming to our society webinar and imparting your knowledge in such a lucid way that everybody is, there are so many appreciative comments on the box. So thanks a lot. And I hope we see you again in a future webinar. So thank you, sir. And thank you, Khurana sir. Over to you.
Thank you to you, ma'am.
And with that, another wonderful evening. And our thanks as usual to our back end, Conferences International, for always giving us a Zoom that doesn't
and
collapse.
Vishal. Thanks to Vishal, who does all
Vishal,
the hard
who
work.
is always there. I think Vishal Mittal is now not only a voice on the telephone, he's become an integral part of everybody's life, and we can't seem to take the next step without him. He's a very solid backbone to the organization. Thank you, Vishal, for always being there. And a very good night, to all of you. And we look forward to the last two programs in this series.
Sir, we are having it further for 6 months, no?
Really? Okay, we will extend that. On public demand, we will extend that.
Yes, on public demand.
Yes, and we have some very good inputs also, that people prefer a pure panel than didactic talks to bring out the messages. So we will stick to that because that's been the consensus so far, and we will bring you a lot more in the coming few months. Thank you very much indeed, and a very good night to everyone.
Good night.
Thank you, sir. Thank you. Thank you, everyone.
Good night. Good night, everyone.
Good night.